many years. Today we're going to discuss planning for the cost of long-term care and try to answer the question, can we afford not to do so? As someone who is 67 years old, I firmly believe that each one of us needs to be self-reliant when it comes to planning for our golden years so that they are not our rusted years. As we all know, long-term care is expensive, so early preparation is key to a successful financial plan. However, according to a recent poll that our first presenter will discuss, most people are not planning for long-term care and are worried about the high cost of this care. And we will be referring to this research called California Voters 40 and Older Are Struggling to Make Ends Meet and Financially Unprepared for Growing Older. So according to that poll, most people are not planning but are worried about the high cost of this care, and so they're doing nothing except worrying about it. Presently, the average cost of nursing home care is $6,000 per month, and if you don't need skilled nursing, then just part-time in-home personal care like bathing, dressing, meal preparation runs at least $1,700 per month. Those are today's numbers. Long-term care continues to rise every year, the cost of it. This year, that cost rose 5.6%. At that rate, in less than 20 years, the numbers I just gave you will double to $12,000 per month for nursing home care and $3,400 per month for just part-time personal care in your own home. Since these increases outpace inflation and Social Security cost of living adjustments, the COLAs, and pension reform will leave many of us without the retirement income that we are counting on. So we are going to have to find new ways to be better prepared for the practical and financial demands of long-term care. Medicare does not cover long-term care services. Most people don't know that. And Medicaid only covers these services after one has spent down her or his assets to $2,000. Long-term care insurance is available, but according to the poll I mentioned, only about 15% of California voters have it, and it is known to be expensive. The CLASS Act, CLASS, was included in the federal health reform to provide beneficiaries who had paid premiums for at least 5 years, a lifetime of $75 per day worth of long-term care services. Unfortunately, the Obama administration recently suspended implementation of the CLASS Act indefinitely. So, what now? Should we save every penny we can and forestall any plans we have to enjoy our retirement years? Should we make improvements to our home to hopefully increase its value down the road, or should we make it more adaptable for us to live in it longer? Should we purchase long-term care insurance? Should we invest smarter, more aggressively? Those are just some of the questions we need to be asking. Today I've assembled, with the great help of my wonderful consultant, Bill Dean, and Matthew Ortiz, I've assembled some of our state's aging and long-term care and financial planning experts to help us answer these questions and guide us so we will be able to afford long-term care services in the future. First, what I'd like to do, we're going to have two panels. I'd like the first panel to come up. That would be Dr. Wallace, Ms. Burns, and Dr. Estes. They could come to the table, please. I will mention a little bit about each one, and then we will have each one of them speak, and then I will ask a few questions. So Dr. Wallace is Associate Director of the UCLA Center for Health Policy Research. He will discuss the recent poll of California voters that I mentioned, age 40 and over, about our preparedness for the cost of long-term care. Ms. Burns is Training and Policy Specialist Consultant at California Health Advocates. She will present an overview of the Medicare and Medicaid benefits and an update on the CLASS Act. Dr. Carol Estes, professor of the UCSF School of Nursing, We'll discuss Social Security's impact on paying for long-term care services and what proposed changes to Social Security could do to our retirement security. So you will each have 10 minutes to present. I'm a former teacher, so we'll be a stickler on the time. And then when the three of you are done, I will ask a few questions. So welcome, Dr. Wallace, and thank you for coming up from Los Angeles, and we look forward to yours and everyone's testimony.
Great. Thank you, Senator Alquist. I appreciate you organizing this important hearing. I think it's important. Well, I also want to thank you for giving about half of my presentation, so I can probably actually fit it into the 10 minutes now. So it's also important, I think, to note that we have over 4 million seniors currently in California, and that number is going to double to 8.8 million in the next 20 years. So the issues of long-term care are not just rising costs, but the rising needs in the state as well. The UCLA Center for Health Policy Research collaborated with the SCAN Foundation in Long Beach this last summer and surveyed almost 1,500 registered voters age 40 and over in the state in both English and Spanish on a series of long-term care issues. And that's mostly what I'm going to pull from in my remarks today. As you know, we're in the middle of a worst recession since the 1930s, and that creates financial struggles that makes it hard to even think about long-term care. If you look at the people who we polled, the registered voters age 40 and over, 60% have cut back on what they would consider extras like going out for meals. Half have used savings to meet their daily expenses. Almost half have reported that their income is declining. 2 out of 5 report cutting food spending, and about a quarter report that their mortgages are underwater, which in terms of putting more money into your house at this point might not make the most sense. What's important is when you look at how this set of financial struggles varies by whether or not a person is a caregiver, we find that caregivers are struggling even more. So not on the tables that I handed out, but if you look at each of those dimensions of financial struggle among the middle-aged and older population, the numbers are about 10, there's a gap of about 10% between people who are providing caregiving, so they're higher, they're struggling more than people who are not providing caregiving. And so not only is the population struggling financially, but people who are caring for those who have disabilities are struggling even more. So when we asked them about their worries about growing older, it's no surprise that they all were worried about paying for the cost of long-term care. And given the data on how they're financially struggling, that makes a lot of sense. What's interesting is when you look at the proportions who are worried or very worried about affording long-term care services in the future, it's relatively constant until you get up to $75,000 and above in an annual income. So it's not just the low-income population, it's the middle-income population as well is very concerned about paying for long-term care. And people who are current caregivers are also concerned. They see what it costs to provide long-term care. So we asked those questions before we told them what it actually costs. So that was just sort of in the generic, are you worried about these issues? And there were about 7 or 8 issues. And then we actually told them what the real costs were, which is what you had just mentioned. And we asked, how long could you afford currently to spend that much if you needed nursing home care and personal aid care? And 2 out of 5 respondents said they could not afford a single month of nursing home care if they had to pay for it today. And about 1 out of 3 said they couldn't afford a single month of personal aid care in their home. So the concerns about being able to afford long-term care are well-founded, and they're even more real when you tell people how much it costs. Oops, and I'm out of order here. So the problem is people can't afford long-term care. So what the challenge is, as you mentioned, is how to get people to engage with this, how to get them to think about, well, what will I do about long-term care? And I think one of the greatest barriers to that is most people don't know what the risk of long-term care is. So currently, data show that when you reach age 65, 70% of those individuals will need help at some point during the rest of their lives with activities of daily living. So when we ask this population, an open-ended, what proportion of the older adult population do you think will need long-term care at some point in their lives? Only over a third gave the right number. So on this chart, there's a typo. It's not 27, it's actually 37%. So 37% gave a number of that was correct or higher, which means the vast majority of people really don't know that when they reach old age, there's a very good chance, better than half, that they'll need some sort of long-term care. Even if they do know that there's a good chance of needing long-term care and it's accurate, that makes no difference in their purchase of long-term care insurance. So you cited the 15% of Californians report long-term care insurance. That basically is not different whether or not they accurately know their own chances of needing long-term care in the future. There's a very small difference among people under and over 65. Caregivers actually have a slightly higher rate of knowing what their risk of long-term care is, but the issue with long-term care is most people, unfortunately, don't want to think about it as happening to themselves until it's there. So what are the implications of this for state policy? I think what's important is to realize that state policy changes affect not only persons with disabilities, but their caregivers as well. So there have been a series of reductions already in state policies that impact low-income persons with disabilities, including reductions in SSI, SSP payments. In January 1, 2009, the maximum amount for a single individual for SSI, SSP was $907. It's currently $830. As you noted, inflation raises the cost of housing and food and medical care, and their ability to pay for that's actually going backwards. We're currently in a situation where adult day health care centers are threatened with being closed December 1st, threatening about 35,000 disabled persons and their caregivers with a loss of services. Okay. Reductions in ISSS with trigger cuts and the elimination of a lot of California Department of Aging programs. So Medi-Cal is important. About 20% of seniors receive Medi-Cal. That's higher for the disabled. About a quarter of disabled seniors receive Medi-Cal. And their caregivers are the caregivers of seniors on Medi-Cal. Sometimes are paid and sometimes are unpaid. So a lot of family caregivers, that's the second to last chart. About a third of family caregivers who are not getting any payments at all, the people they're caring for are dependent on Medi-Cal. So as we cut Medi-Cal services and long-term care services linked to Medi-Cal, we're affecting a large proportion of caregivers in California. So in conclusion, registered voters age 40 and over worry about paying for long-term care, and they have good reason to, because a large proportion of them can't afford a single month of it, and the majority of them cannot afford 3 months. Most people underestimate their need for long-term care, so it's hard to engage them in the topic to get them to think about it for themselves. But a lot of them are caregivers, and the economic crisis has hit all persons in California, but especially caregivers. And as a result, both caregivers and the elderly will be impacted by program cuts, and possibly the best way to get people to think about long-term care is not about themselves, but for the people that they love. Thank you.
Yes. Do I need to turn this on? Okay. As each of you have noted, the cost of long-term care is high. It's very high. It exceeds most older people's, income, monthly income, and that in and of itself causes people not to want to think about this because it seems insurmountable. But it isn't just families. Businesses are affected by long-term care. State and federal governments are affected. And the risk is greatest at the oldest ages, but it's also greatest for women at the oldest ages, because women live longer and are more likely to be living alone at the time they need care, and institutional care is much more common for older women for those reasons. We've got no national or state structure for this issue. Each person that experiences long-term care designs a system on their own based on what they know and where they live. It often occurs during a crisis where decisions have to be made very quickly without a lot of information. And there is no single place people can go to find out how to deal with this issue. The average caregiver is a woman, 47 years old, who will probably spend about 15 years of her life taking care of older family members, almost as much time as taking care of children. Caregivers are faced with enormous decisions about what kind of care, where to get it, how to pay for it, where the family member's money is, how much there is, where is it, how to access that money. They have to deal with legal decisions about who has the power to even make these decisions, because sometimes there are second marriages and there's a spouse involved that is not the parent of the spouse who needs care. They have to make arrangements to pay for care, which means they have to know a lot about the income and the assets and how to access those. They have to know whether the person has insurance. Does Medicare pay for any of these services? They have to know about Medi-Cal. Is the family member eligible for any public programs at home, in the community, or in a nursing home? They may, and it's very likely, have to deal with combinations of these payment sources without much information to help them do that. People pay for care now in a variety of ways. Many people go into living arrangements that combine the living arrangement with care. Some people are in retirement communities like that. Some are in assisted living. Some are using VA services or California veterans homes. Some self-fund, most self-fund with their own money until that runs out. Some families contribute. Sometimes there are insurance benefits, but not often. And then Medi-Cal becomes the payer of last resort. The Medicare benefit, which every senior believes they have 100 days of care in a nursing home, is absolutely not true. Medicare, as you noted, only pays for skilled care, services that are delivered by professionally licensed people, and the type of care that people need most often is not that kind of care. It's what is often referred to as custodial care, a term I'd like to see stamped out in favor of personal care services, which is what people need when they need long-term care. HMOs and Medicare Advantage plans don't do anything different under Medicare than Medicare does itself, because they are simply providing Medicare benefits. Most long-term care is personal care services. It is not skilled care. It's done by unskilled people, usually family members, until that kind of care can no longer be delivered that way. What most people don't know about Medi-Cal is that there are spousal protections for spouses. So a spouse who can be in a nursing home under Medi-Cal's benefits, while the spouse at home is entitled to keep community income and resources beyond what would be available to that person if they needed Medi-Cal. So most people don't know that they have these protections built into the law. Long-term care insurance is often proposed as the solution to long-term care and something that will save the state's Medicaid programs. That could not be further from the truth, because insurance is a private profit-making industry. They are not in the business of insuring people who already need care. You have to be young enough to be able to buy coverage. You have to be wealthy enough to pay for it when you get it and in the future when rates go up. And you have to be able to qualify by the medical underwriting, so that if you have health conditions already, you're not likely to get long-term care services or long-term care insurance. There have been 5 companies that have recently raised rates in excess of 40% on long-term care insurance. That's a devastating situation for people who are paying $2,000 and $3,000 a year already, and are now being faced with additional costs with the same resources. The federal program, long-term care insurance program for federal employees, and the CalPERS program have both had significant rate increases as well. We have some pretty strong standards in California for long-term care insurance, some that are said to be the strongest in the nation, and I believe that's true, so that people who buy long-term care insurance in California are getting a high-quality product, but it is still a private insurance product. The Class Act, which you made reference to, that notion of a federal insurance program for long-term care has been with us since before the 80s. But back in the years when the Pepper Commission was meeting and Senator Kennedy had his first bill on this issue, that subject has not been discussed for 20 years until the Class Act was incorporated into the ACA. It's sad that it has been, for the moment, put on hold. I hope it's for the moment. I hope that the legislation won't be repealed. While the structure of the program itself had many problems that led to the suspension because it could not be made fiscally sound with the way that that it's been written, the idea itself is a good one. There is a place for a national health insurance program that could, in fact, work with private insurance. The federal program couldn't do everything and shouldn't, but there is a way to combine those two ideas and make them work. But it is going to take some work to have that happen, and it's going to have to take some political will, which is not only absent at the moment, but antithetical to the whole idea. So I'm relatively sad to see the program put on suspension, but I'm hoping that it will not be ultimately repealed and that we can, through states and federal government, come together with some way to address this very significant, very expensive program for people in this country. It's sad that every single person who encounters the need for long-term care does this in their own little bubble. They don't have the information they need to make the decisions that need to be made. And every program we have in this state, as good as it is so fragmented and so inaccessible to people when they first need this kind of care that there is no comprehensive way to deal with this topic. If we don't do anything else, maybe we can come to some solution for a single way for people to access the services that are available in their community and make the decisions that they need to make. Thank you.
Thank you very much. Dr. Estes.
Thank you.
Welcome.
I am also bring greetings from the National Committee to Preserve Social Security and Medicare and our foundation. I am board chair of both at the current time. I want to emphasize how important Social Security and Medicare both are for a bedrock of long-term care, because the resources that Medicare and Social Security provide really are an enormous shield against draconian poverty among the elderly, and particularly among people of color, communities of color among them, and particularly for women and for those people who are not married or divorced or single. In terms of enormous poverty growth that would occur if we didn't have Social Security. Over 60% of African American women would go into poverty at age 75 and over without it, and comparable numbers of Latinos and even white women, close to 58%, very close to 60%, would be in poverty. And interestingly, men are very close behind in terms of the poverty numbers. Even white men, 48% of them would be in poverty without Social Security. And we're speaking about a very modest income of $13,000 to $14,000 a year. So that speaks to how close to the rim most older people are. And it's interesting and sad to note that of Medicare beneficiaries, half of them are within 200% of poverty. And, of course, you get into looking at categories of people of color and rising age, and those near poverty numbers rise. So We, along with many others in California and elsewhere, are extremely concerned about the wholesale attack on Social Security and Medicare, and of course, with the Subcommittee and the big budget brouhaha in Washington these days, there is no end of mischief afoot. And I want to, however, say that the health care reform bill has a lot of provisions in it that are important to long-term care. And although some of them are just demonstrations, we must do everything, in my view, to stem efforts at any form of repeal of the Affordable Care Act health reform bill. And we must keep the promise of Medicare as a universal and earned right, and that means no to vouchers, no to privatization, no to steal attacks, and double no to raising the age of eligibility for Social Security or Medicare. We've already raised it for Social Security. It's coming up to age 67. We did that in 1983. Every age raise is devastating for the vulnerable population, which is very high among the elderly and the oldest old and the women and the people of color. The details are provided in what I have sent forward. So we need to strengthen Medicare and not cut it, and just say no to the misguided fear-mongering and efforts to repeal health reform. And we have our own Nancy Pelosi from California to profusely thank for putting her life on the line in multiple forms and ways to protect Medicare beneficiaries and make improvements in that act, such as lowering the cost and eventual closure of the Part D drug donut hole costs and eliminating copays and deductibles for preventive care, and the free annual wellness visits and individualized care plans never before offered, as well as a lot of improved care coordination and other innovations. So we have 4.5 million Californians dependent on Medicare, and many duals, that is Medicare and Medicaid beneficiaries, Medi-Cal as we call it here, that are in great danger under what are current proposals and suspected possibilities for draconian cuts in Medicaid, which is extremely worrisome. I do want to speak just a few moments on the thank you, on women. Oh, wow. I'll try not to go that long. It gets hard, I'm sure, listening this long. Women's unpaid long-term care is something that we hear a lot about. And I have been writing and talking about it in new ways. It's really, I see women's work in long-term care, unpaid work, is really should be reconceptualized as a free rider problem in long-term care, and that is with California, in this case, free riding on the backs of women's unpaid long-term care work. And there's some couple of new exciting caregiving reports that have done cost analyses. One that has just come out from the MetLife Mature Market Institute, which shows that for the average woman who's doing caregiving age 50 and over, it's $334,000 lost in Social Security, private pensions, and wage income. And I actually have a copy of the report if you would like it. And it is, I call it it's the invisible hand. It's the invisible hand that is really bailing us out, and to whatever extent we're bailed out in long-term care. Not to minimize the fact that more men are doing the caregiving, but between 75 and 80% of that work is done by women. It's done without pay and at great cost. And I've been fascinated by this NIH study funded by the National Institute on Aging by Schultz and company that was in JAMA, the Journal of the American Medical Association, that showed the mortality. We talk a lot about depression and lost income and health, chronic illness effects of burdened caregivers. But this speaks to a shortened life expectancy of up to 2 years for caregivers that are under stress. This is an enormous contribution. And so we must do something about long-term care. And we've got to do something about adult day health care. We've got to do something about IHSS. California, we all know, was the pace setter, was the model, the innovator, the first up and out on these things. And we've just got to do what we can to restore these programs in some form or another, and to fight like heck to get the Class Act retained and restored. Okay. So I just would want to close with some public opinion information that the American public, we have been doing surveys, and a number of others have, very recently in the last 2010 and 2011. And it is clear that Republicans, Independents, Democrats, and Tea Party members alike, all 65 to 85%, believe that Social Security has nothing to do with the federal deficit, which it does not have anything to do with the federal deficit, and it should not be cut. And almost equal proportions are opposed to raising the age of Social Security eligibility. And maybe yesterday, the Demos organization issued this Young and Invincibles poll of young people age 18 to 34, and find that among the top priority for Congress, one of their top priorities is, quote, making sure Social Security is available for people in my generation. And this was in 80% and above of those persons, or young people, really understand that it's important to have it, even though they don't believe it's going to be there for them. And I would just close with saying another very exciting report has come out from the Commission on the People of Communities of Color. It's from a commission to modernize Social Security, and it really has the reforms that need to be undertaken, which would help in long-term care, increasing those age 85 and older's benefits and a whole bunch of other benefits. And the main vehicle for paying for all this is scrapping the cap, which means the cap on payments into Social Security based on wage income of $106,800 should be removed. Thank you.
Thank you. The first question would be to anyone who wants to answer it, and then whoever doesn't, the other two, I will have specific questions for you. What are other states doing that we could replicate in California to get people more ready for the cost of long-term care? For example, I understand that some states are looking at letting everyone in the state buy into the state's public employee long-term care insurance program at the rates offered to state employees.
I'd like to address that one.
Okay.
States do different things in terms of their their long-term care program for their state employees. California is rather unique in having set up its own independent program that is not connected to any insurance company. It's completely self-funded. And that program has not had an open enrollment now in 3 years, and has had significant rate increases, 3 over its 15-year history. So I'm not convinced that opening that up to California residents would be a good thing without some dramatic revisions of that program. And I'd like to reiterate the fact that I don't think that commercial insurance is the answer to this problem. There are too few people who can afford to buy it, and there is no stability in those premiums.
So what is the answer?
The answer, I think, has to be a much broader answer, one that combines some sort of a national or even a state insurance program that people can enroll in, with some strong controls that will make it fiscally sound. And the private insurance industry can do what they've done with Medicare, which is to wrap around or expand on benefits and offer benefits beyond what a public program might offer.
Thank you. And so I will have a question for Dr. Wallace and then Dr. Estes. Dr. Wallace, very briefly, if you could say what you think are the top 3 findings of the survey you talked about, and what do those findings tell us as a state? What do we need to do next?
So the top findings are sort of in the headline of the poll. People are struggling, they're not ready for long-term care, and they can't afford it, which I think gets to Bonnie's comment about long-term care insurance. Most experts agree can't be done privately because most people can't afford to purchase the premium costs. So I think that's sort of the top line on the poll. What should we do about it? I guess I would concur probably with what Carol and Bonnie would say is I don't think anybody's talked about a equivalent to the Class Act at a state level, but I don't see why you couldn't do that. I was in Washington last week at the American Public Health Association on a panel about the Class Act, and they had a series of reforms that they said if there was tweaked here and tweaked there, it would actually be actuarially sound. So it wouldn't have to be a drain on state benefits. And so you could do that with then the private insurance as the wraparound. I think that would be
Thank you, because I'm actually looking to find some action items that I could translate into legislation. Mm-hmm. Thank you. Okay, and Dr. Estes, you spoke to this, but I'm just going to ask you to tweak it a little more. We talked about, with our fragmented long-term care system, the bad things that happen if Social Security, Medicare, and Medicaid would get cut. And so just taking it a step further, do you foresee institutions stepping back and families and communities stepping up, or will there be more elder neglect and deaths?
I do not see how families can step it up a whole lot more. It's pretty hard to imagine. Sorry, I jumped into the last part of your question first.
That's fine, and I relate to it because my late husband was 36 years older than I am, and I took care of him by myself for many years. So, and he passed away when he was almost 98.
Well, so. It always makes me smile, lest I cry, about how we have to do more caregiving informally, when in fact we're already doing about 88% of long-term care. How much more can we ask families to do when the economy and the economics are requiring people to take 2 and 3 jobs in some cases? So in terms... If I could just go back a little bit, I think Steve's and your idea and Bonnie's idea, a class act for California would be a class act. I think that should really be considered. I'm always so amazed that I was just at a huge long-term care meeting in New York a few days ago, and there was no discussion of the German long-term care plan, which does require a very small payroll tax, but it covers everybody regardless of age. It's based on the functional assessment. It's like cash and counseling in that you can use the funds if you're eligible for paying for caregivers like we do in IHSS, or flexibility to put ramps in your house or whatever it needs to keep you at home. And because it's a universal risk pool, it's cost saving in terms of what are boomerang effects in hospitals, nursing homes, a lot of Medi-Cal costs we would have. So, I think looking at class in Germany and some lessons we've learned there would be an invaluable step forward.
There was a bill last year proposed by someone from San Mateo County as part of the senior legislature, a California Class Act. I'll look for that information, and I'll email that to Bill, because they did a lot of work in preparation for that bill.
I wanted to mention that when you mentioned in your comments that women basically start caregiving when they're 47, and by caregiving we mean to those around them, not their children, who they care for from day one when they're in their teens or 20s or 30s, or sometimes their 40s. But when that happens, those are prime years for anybody to earn a lot of money. And if during those years you're spending it caregiving really for free, then when you get to be 70 or 80 years old, you don't have the kinds of resources to take care of yourself.
I have a daughter who's spent 10 years taking care of 3 of her husband's family members, 2 of them with Alzheimer's. And she is a perfect example of what you're talking about. She was a highly paid person within the computer industry. She had 2 children at home, and she ended up having to leave that job and all of the benefits that went with it to take care of those 3 people over that 10-year period. 2 of my other daughters have cared for mother-in-laws, one who's deceased and one who's entering into a facility soon. And they are examples of that caregiving responsibility that falls on the shoulders of daughters and daughter-in-laws primarily.
Thank you. Well, I'd like to thank this panel very much. It was very interesting, and it will help us chart a path for the future. Thank you.
Thank you.
And we'll have the second panel come up. Dr. Shen, Mr. Chamberlain, and Mr. Roth. The second panel will identify for us some tools to effectively and safely plan for the costs of long-term care. We'll start with Dr. Shen, who is the chief of the Long-Term Care Division at the Department of Health Care Services. He will present on the department's Partnership for Long-Term Care, a public-private partnership the state has with long-term care insurance companies that educate consumers on how to insure for their own long-term care. After that, we will have Michael Chamberlain, a certified financial planner with Chamberlain Financial Planning, LLC. He will discuss how to incorporate long-term care costs into a financial plan. And then we will have Andrew Roth, Director of Education and Outreach at the Department of Corporations, who will tell us about the department's Seniors Against Fraud programs, which has educated thousands of Californians about how to avoid investment fraud and financial scams. You will each have 7 minutes, and after the 3 of you are done, then I will have just a few questions. So we will begin with Dr. Shen.
Thank you, Senator Alquist. Thank you for the opportunity to speak. Okay, as you know, Department of Health Care Services is the primary Medi-Cal provider, fund a lot of the Medi-Cal services in the state of California for our low-income, senior, and disabled people with disability. Interestingly, in our division, we do have a program that does not particularly focus on providing services to the lower-income Californian, but really have a program try to promote a long-term care insurance program so that folks can prepare for the long-term care before being impoverished. Okay, so I would describe a little bit about the program and proceed to answer any question you may have. Okay, so the program was conceptualized in 1990, so it's really a long-standing program. It became part of the state plan as a pilot program in 1993 with the support of Robert Johnson Foundation in preparing and planning for the development of this program. And by 1994, we actually have the first commercial insurance organization offering a long-term care insurance with California stamp of approval on it. Okay, that we call it partnership policies. Okay, and by 2004, it became a permanent program under our state plan. So let me say a little bit about the goal of the partnership program. We basically have three goals. One goal is basically try to educate our Californians about the risks and the cost of long-term care. And this is we are trying to achieve that through presentation in the communities, reaching out to communities. We have a website called Are You Ready? So folks can basically go onto the website to, if they know about a website, so this is a challenge, but they can go on the website to basically assess what was it implied for them in terms of their health status as well as their long-term care needs, and what does it mean to buy a long-term care insurance. Okay. The other piece that you probably are very familiar with, that on an annual basis or on a quarterly basis, we do a lot of mailings, so that in your mailbox you will get some information from our department regarding long-term care insurance. Okay, and that mailing reach about 5.8 million Californians on an annual basis. So this is what we do, try to educate. And I think the challenge for us has always been is that trying to have enough resources to send folks out into the different communities to speak to people face to face and work with them to help them to understand what long-term care means. The second goal of this program is basically actually work with the commercial insurance industry to develop insurance product that's affordable and of high quality. And as of this time, we do have 5 insurance that is providing what we call partnership policy, and this is CalPERS, New York Life, John Hancock's, Glenworth, and also Bankers Life and Casualty. And so they have been offering a product that with our specificity in terms of what the benefit should be. And I will talk about that a little bit later. At this point, we have 115,000 policy that's active, and this is growing at approximately a steady pace, about 10,000 a year. So in spite of the economy that we see some downturn in economy and as well as downturn in people buying properties, but nevertheless it's very stable, 10,000 policy increase every year. Okay, and of all these active policies, since the beginning of this program, we have about 3,000 policyholders actually in benefit. They're actually benefiting from the policy they purchase. And to qualify for benefit, we set a very low requirements for them to get benefits. This will be people with 2 activity of daily living limitations, which is actually very generous. But if you look at our Title 22 in terms of when would people qualify for nursing homes, and it's much tighter standards. So this is a much generous policy in the sense that people can become eligible for the benefit if they have 2 limitation and activity of daily livings. And I think of those 3,000 folks who have been using benefit, most of the benefit they choose to receive is actually in the home, okay, for personal care services. But there's also a fair sizable amount of people who choose to receive care in assisted living facilities, okay. 2 minutes. I will talk fast. Okay, goal number 3, okay, is that because we are as a department, we're using tax dollars to support Medi-Cal services, and long-term care is one of the services we support. One of the approach that we have is basically the goal is try to cost avoidance. Okay, I think we have an estimate as of March of this year. We estimate that we have avoided Medi-Cal costs for long-term care services by about $31 million. So this is definitely a focus on not just on the provision of services, but try to get people ready and try to take responsibility on the long-term care costs. So in terms of target population, we don't market to anybody. We market to specifically population that's 55 years to 75 years old, those people at the cusp of needing long-term care and with income between $28,000 to $93,000. So we're not talking about low-income folks. And they have assets of $47,000 to $250,000. Okay, and most policyholders are surprisingly men. 60% are men. They are age 69% are 55 years and older. 72% are married and living with spouse, but they interestingly also have very small families. Okay, they usually have 79% has one or less children or no children, basically. So it's really people preventing, knowing that they don't have a family support, they don't want to impoverish the spouse, they are buying the long-term care insurance. And so in terms of policy benefits, okay, it varies, depends on coverage. We offer two kinds of coverage, really a facility-based coverage as well as a comprehensive coverage that cover both out of the facility as well as in-facility coverage. And people can buy 1-year policy or buy 2 or to 4-year policy. And so, and the benefit is basically paying 70% of what private nursing home pays. It's about $170 per day.
As our time's up, could you just state your website where someone could go to and research
the
this?
website is Are You Ready? RUREADYCA.org.
Great.
Okay. Thank you.
Thank you so much.
Thank you for the opportunity.
Thank you so much. And then I'll have a question for you later, too.
Okay.
Mr. Chamberlain.
Good afternoon, and thank you for having me. As a certified financial planner, I work with people to help them make better financial decisions to balance current needs with future needs, as well as goals. As perspective, I was asked to review what it is I do as a financial planner in the financial planning process. I want to stress that I'm a fee-only planner, and what makes me different than most is I don't sell any product. People pay me by the hour. Therefore, the advice that I give them, they know it's objective, and there's no commissions to influence that advice. The financial planning process involves making contact with the person initially, having a get-acquainted meeting to make sure we're suited well to work together. We then need to prioritize what their goals are, collect data, analyze that data, formulate recommendations, present the recommendations in an organized fashion, including recommendations to achieving those goals based on their priorities. Unfortunately, many times you can't do everything that you want to do. The client then implements those plans and then returns on a periodic basis to update the plan to make sure they're on course to meet those long-term goals. A financial planning misconception is just for the wealthy. Well, my clients range from 24 to 101. Their income ranges from that of a part-time student to $2 million a year, and their assets are a negative net worth to multi-million dollars. No two clients are alike, but the process is the same, and that is we need to look at things globally. What's their current financial status as far as budget and cash flow? Do they have debt management? Talk about education planning, retirement planning, analyzing their current investments, giving them recommendations as to how those investments can give them the maximum return for the level of risk they can afford to take. Estate planning, making sure they have the proper documents to protect themselves if they are incapacitated, and then to pass those assets along when they're gone. And lastly is risk mitigation. How do we take care of the bad things that occur in life? And that includes long-term care. A financial planner helps clients really in 3 ways. The areas in which they know they need help, the areas they don't know about, and the areas they think they know about and they're wrong. Long-term care falls into the second category and third category, and that is most people are unaware of it and they don't know about it, or they think they know about it and they're going to rely solely on family or the family revolver to end things. It's not based on reality. The area of risk mitigation is about dealing with those bad things, and there's really 4 ways to deal with any risk. You either avoid the risk, you pay the price if that event occurs, or you transfer the impact of that risk to someone else, or a combination of those 3. Avoiding the risk is very easy when it comes to injuring yourself skateboarding. I just don't skateboard. However, that's not very realistic when it comes to long-term care. Mental and physical issues can impact anyone, including presidents and the Pope. All of my clients, regardless of age, get a review of long-term care. We provide them unbiased facts. We provide a spreadsheet to show current costs, and we project it out based on compounding interest to at age 85. And when they see long-term care costs in excess of $1 million, it does get their attention. Everyone's asked to develop their own long-term care strategy. How people respond to that discussion varies based upon their age and their income. If you talk to someone in their 20s and 30s, they don't even address disability insurance or life insurance, so they're not addressing long-term care. As people start hitting middle age, they might have the opportunity to address long-term care, and that is the sweet spot in my mind, late 40s, early 50s. When they start becoming older, there is the issue of they can probably afford long-term care coverage while they're working, but they can't afford it when they retire. So as a planner, my ideal approach to long-term care is plan on using family if you can, have assets set aside to pay for some period of long-term care, transfer some level of risk to the California Partnership Program, have additional assets in case the partnership policies exhaust, and lastly, rely on Medi-Cal. You're using a number of different approaches to deal with the problem rather than just on one solution. There are 3 reasons I recommend the partnership policy. The first is the stability of the premium. It's harder to raise the premium price of a partnership policy than other commercial policies. It's a policy designed that does not have extensive bells and whistles, and there's the coordination of Medi-Cal benefits and asset protection. The hurdles for long-term care proper planning include most people do not plan. They react after the fact. Most people overspend on current funding and don't fund the future. Some have a Cadillac or nothing approach. If I can't have an unlimited partnership policy, I won't have any at all when there's in fact a 1 or 2 year policy available. America's mindset is the government will take care of me. Well, I'm not sure. I think everybody in this room knows that every government level has a funding problem. There's a lack of understanding about costs as well as the inflation factor. There's also the denial factor. My family, no one in my family needed long-term care. I'm not going to need it. Or my family will take care of all my long-term care needs. People fail to make long-term care a priority in their planning. And lastly, the cost of long-term care is very expensive. The higher the cost, the lower the utilization. In conclusion, fee-only planning can help clients balance current needs and future needs. But one of my favorite sayings to clients is, you can afford anything you want, you just can't afford everything you want. No one wants long-term care, so it's not very easy to convince them to plan for long-term care. Thank you.
Thank you very much. Mr. Roth.
Madam Chair, thank you for this opportunity. Saving and investing are critical tools to help Californians prepare for potential significant long-term care costs. Losing even a portion of their savings can have a devastating impact on a senior's financial and physical health. While according to the Office of Older Americans, between half to 2/3 of American seniors do not have enough savings to see them through retirement, Americans 50 and older nonetheless control 2/3 to 75% of the nation's wealth, making them prime targets for financial fraud and scams. The Department of Corporations works to protect investors, especially seniors, through regulation, enforcement, education, and outreach. Seniors Against Investment Fraud, or SAFE, was created by a grant in July of 2001 to educate Californians about the importance of saving and investing and about telemarketing and investment fraud. In recognition of California's rapidly growing senior population and the high incidence of senior financial fraud, the SAFE program was permanently added to the department's budget in 2005. Since January 2006, Seniors Against Investment Fraud, or SAFE, has conducted over 3,200 presentations attended by some 188,000 seniors and distributed over 286,000 SAFE booklets. SAFE works to protect seniors from financial and investment fraud by educating them about the warning signs of fraud and by providing consumer protection and resource materials. SAFE seeks to protect seniors before they fall prey to con artists and to file complaints with the department, leading to increased enforcement actions that help shut down more con artists. The program works by DOC outreach staff conducting SAFE presentations at places where seniors gather, including senior and community centers and retirement group meetings. DOC staff also research, write, and produce consumer financial and investor protection publications, including the SAFE booklet for statewide distribution. The SAFE booklet is available in English, Spanish, Chinese, Tagalog, and Korean and Russian versions are planned for the coming fiscal year. The SAFE booklet addresses a variety of financial and investment topics important to seniors. For example, investment scams, reverse mortgages, annuities, elder financial abuse, end-of-life paperwork, and the booklet also includes a detachable check before you invest form for use with financial services professionals. The booklet and presentations also promote the department's toll-free number 1-866 Ask Corp as a way to check the licensing status of a financial service professional or product or investment opportunity. Outcome measurements include the number of events attended, the number of seniors at those events, and the number of educational booklets distributed. The SAFE program, replicated in a half-dozen other states, utilizes a peer-to-peer education model where seniors teach other seniors about financial concepts, including fraud and investment scams. The model relies on community-based and local government organizations such as retired senior volunteer programs to recruit volunteers and help distribute materials. In fiscal year 2010-2011, SAFE partners donated approximately 1,000 volunteer hours by conducting presentations and staffing resource tables at events. SAFE collaborates with key partners at local, state, and federal levels to identify distribution networks and leverage resources. The Department of Financial Institutions, Department of Insurance, Department of Consumer Affairs, Commission on the Status of Women, State Controller's Office, and others all contribute expertise and resources. SAFE has also participated in dozens of senior scam stopper presentations with members of the California legislature in conjunction with the Contractor State License Board. Other groups such as Kiwanis, Sons in Retirement, and the Elder Financial Protection Network also help SAFE reach seniors. SAFE recently entered into partnership with the Federal Consumer Financial Protection Bureau's Office of Older Americans. The Department of Corporations also participates in a national elder financial abuse awareness effort called the Elder Investment Fraud and Financial Exploitation Prevention Program, also known as EFI. California and 26 other states are participating in this program. The goal of the program is to train physicians and adult protective services workers who come into contact with seniors about the high incidence of mild cognitive impairment, or MCI, among seniors. Approximately 1 in 3 individuals over the age of 70 suffers from a medical diagnosis that includes mild cognitive impairment, which means they are especially vulnerable to investment in financial fraud, as mild cognitive impairment is centered in the orbitofrontal cortex of the brain, which regulates risk-taking behavior. So, for example, someone who, for many years or even decades, was risk-averse and never gambled, suddenly enjoys going to the casino and sees no problem in dropping thousands of dollars for enjoyment in one day. Dr. Natalie Denberg, the author of the study and the author of the research that I was just describing, makes the critical point that as seniors age, the financial and life decisions that they must make, such as long-term care, increase in complexity, scope, and gravity, while for many, their mental abilities and decision-making capacities are decreasing significantly at the same time. The EFI program also highlights the financial fraud prevention and consumer protection resources offered through the state securities regulators, such as the Department of Corporations. Thank you very much.
Thank you very much. And so, Mr. Roth, I have my first question directed to you, and I'm going to put 2 questions together.
Sure.
The first question is, are there new types of investment fraud or any types of scams that are currently on the rise?
The type of fraud that our enforcement attorneys and
the other completely different part that I was going to put in was, how has your program been impacted by budget cuts?
The budget cuts have merely helped us to, or made us be a little bit more creative in finding ways to outreach and leverage resources. We emphasize partnerships and tapping into existing distribution networks in order to continue to reach seniors and accomplish our program goals. As far as the incidence of fraud, if there's any new kinds, what we see the most of both from our own enforcement attorneys and those in other partner agencies. A lot of times it's the affinity fraud element because no group is immune to it. That's ethnic groups, religious groups, cultural groups. For example, the Bernie Madoff fraud wasn't just a Ponzi scheme. He was also preying on many of the members of his own religious faith, the Jewish religion. So that kind of, you let your guard down at the door when you're among your own. That's what many times the fraud is based on.
So you have to be cautious, careful, and critical with everyone.
Always, yes. Whenever I talk to seniors, I tell them just because you're, at your church or your senior center, if somebody approaches you and starts talking about, I've got a great investment, I want to talk to you about your money, that's a red flag.
Thank you. Mr. Chamberlain, in your testimony, you acknowledge that the need for long-term care services is a potential financial risk that people ought to plan for. Do you think, putting you on the spot here, you don't have to answer this if you don't want to. Do you think, although I usually require it of people, but on this question, do you think most other financial planners advise their clients of this, or is there a stigma attached to aging that stops this from coming up?
I can think of no reason that there would be a stigma at all. And as far as other financial planners who are driven by commission base, they may not bring up alternatives other than insurance and would stress to buy a policy. And since the bigger the premium, the higher the commission, they might tend to oversell to a point where a person really can't afford it now, let alone in retirement.
Do you think there's anything the state should be doing in this area for them?
Yes, two things, and I'm glad you asked. First thing is that each household has to make decisions about their priorities, and we can't fund everything. Medi-Cal is a very viable, important part to a lot of individuals, particularly seniors. Unfortunately, there's a lot of things happening out there to cause people to acquire Medi-Cal benefits when they really have assets. And the salespeople using techniques or other organizations stressing activities that cause these people to access benefits when they really have assets is stealing those resources from other important segments of the community and state that need and are dependent upon those resources. So number one thing I think could be done would be adopt the federal guidelines for Medicaid and not the more lenient interpretation that the state has, and pass whatever legislation necessary to close off the loopholes of transferring assets. The other thing that can be done, which I think goes along to what you were referring to earlier, is I'm aware of one, it's enforcement. It's great to make people aware of it, but let's enforce it. There was an agent recently in my area who was found by the Department of Labor to be in violation of securities laws. She was sanctioned. 2 district attorneys found her to commit numerous other violations, both of which them extracted monetary penalties, but she still has a license and she's still selling to seniors.
Yeah, that's wrong. Thank you very much. Okay, Dr. Shen, 2 questions put together. First one, how can the department's Partnership for Long-Term Care increase participation by insurers and consumers? And the second part, are insurance companies leaving the partnership, and if so, why?
For the second part of the question, we have a stable group of insurers. I think there's insurers coming and going, but there's always insurance we're able to maintain. The 5 insurance offering the long-term care policy through partnership. We are working on try to work on the 6th one, so that basically there will be more product out there, so that there's more competitions, that senior have opportunity to have other options, and a lot of our limitation has to do with our staffing. number of staffing that we have. We have only 4 staff in that component. Try to monitor and oversee these 5 insurance company offering product, training their sales agent to make sure that they make appropriate representation. So a lot of the issues surrounding our staffing capability of reaching out to additional insurer to offer more benefits. So I think that's sort of like the limitation that we're dealing with right now.
Thank you very much. Well, thank you, panel 2. I really appreciate it.
Thank you.
And this is being televised, so there will be a lot of people who will be educated by what you all, both panels, have been saying. We'll go first now to, is there any public comment? Oh, come on up, Peter.
Hello, and how are you?
Good.
It's good to be
see
here.
you.
Peter Hansel, Executive Director of the CalPACE, which is the statewide association of PACE programs, which you're very familiar with. PACE is not something you think of when you think of long-term care planning and insurance and things like that, but I did want to let you know that PACE programs are thinking of adapting their program in ways that might lend themselves more to those kinds of goals. So the PACE organizations are exploring, for example, with the Federal Centers for Medicare and Medicaid Services, program flexibilities to allow them to expand the population that they serve. So you know that currently you have to be over 55 at a nursing home and qualify for nursing home placement at the time you enter the program. So what they're seeking is flexibility to lower the age and also to serve a less impaired population that might be at risk of nursing home placement. And also for those that don't have low income, this is another interesting avenue, those Medicare beneficiaries that are not on Medi-Cal, exploring the idea of a buy-in of some kind. So this could be a potential solution to explore, and I just wanted to make you aware of it. I've given Bill some materials on that, and I'm happy to keep you up to date as we go.
Well, I really appreciate it, and it's great to see you. For the few of you who don't know, when I chaired the Senate Health Committee, Peter Hansel was the chief health consultant guru. He did a fantastic
indeed.
job.
Fabulous chair. Yeah.
Thank you.
All right. Okay.
I have some closing comments, and then that will be it. Today, we have heard how Californians view planning for the cost of long-term care, i.e., how most Californians are not really planning for the cost of long-term care. We also learned what tools are available to better plan for the future while safeguarding the present, and certainly that's what we all want. I remember in August when the poll results first came out, I was struck by how it was that most Californians could not afford more than 3 months of long-term care, and from what I heard today, it's much less than that. About 1/3 could not even afford 1 month. I guess it should come as no surprise that most people have not planned for long-term care, because the thought of growing older and needing help on a daily basis is very scary for many people. Meanwhile, the added pressure of today's economic realities, the high unemployment rate, homes underwater, state and federal budget cuts, eroding services for millions, can keep many people with their heads firmly in the sand. But we can't afford, literally, we cannot afford to let this continue or to let this happen. We know that it's happening, but it cannot continue. Too much is at stake. We have to look ahead at it, and we must start planning now. Our first panel, and I want to say that all the panelists in both panels were really excellent, and I thought really educated us. And I'm hoping there will be, hundreds and thousands of people who will be watching this when it is shown throughout the state. Our first panel illuminated so well public health and safety net programs like Medicare, Medicaid, and Social Security that they can only do so much, and we know how much they are currently under attack. While we need to protect these vital programs, we also need to do a better job of preparing to pay for at least part of our long-term care, to be self-reliant for our own care. because there certainly is one thing that will not escape any of us. You know, we all will die, not to be morbid here, but we need to plan for that so we don't cause a great burden on our families, and so that our final years are the golden years, as they're supposed to be, and not the rusted years. Our second panel presented an excellent framework of long-term care and retirement planning options that can move us in the right direction. If you hadn't heard before about long-term care insurance or financial planning, I hope this hearing informed you. I know in my own case, I took care of my long-term care insurance when I was about 55 years old, or in my early 50s. And if you didn't know how to avoid investment fraud or financial scams, I hope you will present it from the tips presented today. I would like to thank Dr. Wallace, Ms. Burns, Dr. Estes, Mr. Shen, Mr. Chamberlain, and Mr. Roth for their excellent presentations. And I want to thank all of you for coming, because I know there are probably 82 and a half places you all could be instead of being right here. So I'm certainly an advocate of self-reliance planning for our future, and I do believe this input we received from you will be a step in the right direction. Thank you for coming. Meeting adjourned.